Senate bill at this time of the year.
Live on the show.
Okay, welcome back, folks. This is House Corrections and Institutions. It is Wednesday, April 23rd. We're continuing going through draft 2.1 of House Bill 32 with our legal counsel, Katie McQuinn. We left off, I believe it was on page 7.
Line 15.
Line 15. So we are in the MOUD. Is Tony on Zoom at all? He was probably gonna come in around 3:30 though, right?
That's right. I don't believe he's here yet. I will let him in as soon as he does arrive.
Okay. So Katie, it's all yours if you could identify yourself for the record.
Sure, Katie McLean, Office of Legislative Counsel.
We're gonna get through this bill today
Okay,
and get another draft.
oops,
A definition.
screen is paused.
And another draft so we can,
Okay, so we were on subsection C.
yes.
Okay, if at any time an inmate screens positive as having an opioid use disorder, the inmate may elect to commence medication for opioid use disorder if it is deemed medically necessary by a healthcare practitioner.
So I think we have to be very clear what this language says. The inmate may elect to commence MOUD if it is deemed medically necessary by a healthcare practitioner. So the inmate may want it and want to commence it, but it's not up to the inmate's decision. It is up to the healthcare practitioner and it has to be deemed medically necessary. So even though somebody wants it, doesn't mean they get it.
But they can say no, even if the healthcare person says it's
Mhm.
right.
And the change here is not identifying the specific type of medication.
Mhm.
Is the screening positive and being deemed medically necessary redundant? Are there instances where they could screen positive and the practitioner would say, nah?
I think that's more of a question for a healthcare provider. I think some of the testimony you heard indicated that the practitioner was still going to make a more nuanced decision based on what the person had been taking in the community.
Guess they could be taking something else,
Good as well.
but maybe they only have buprenorphine in the facility or some other type of medication.
Okay, thanks, Katie. Yeah.
Mhm.
Yep, good.
Goes on to say the inmate shall be authorized to receive the medication as soon as possible and for as long as medically necessary. Top of page 8, nothing in this subsection shall prevent an inmate who commences medication for opioid use disorder while in a correctional facility from transferring to a new medication prescribed in the course of medication for opioid use disorder if the new medication is deemed medically necessary by a healthcare practitioner and the inmate elects to commence the new medication as recommended by a healthcare practitioner.
So if they could go from bupe to another type, or at the time when we did this, it was basically bupe to methadone. But now there may be more things available, so you want broader language.
The specificity is not there anymore.
And this would allow, if down the road there are injectables.
What? Subsection D, the healthcare practitioner who makes the clinical judgment to discontinue a medication prescribed in the course of MOUD shall cause the reason for the discontinuance to be entered into the inmate's medical record, specifically stating the reason for the discontinuance. The inmate shall be provided both orally and in writing with a specific explanation of the decision to discontinue the medication and with notice of the right to have the inmate's community-based prescriber notified of the decision. If the inmate provides signed authorization, the department or its contractor shall notify the community-based prescriber in writing of the decision to discontinue the medication.
So the inmate has to sign authorization. to notify the community-based prescriber.
Mhm.
It's up to the inmate to make that decision, not the medical provider. So sometimes the inmate may not want to notify the community-based prescriber.
It's funny.
It's going to say.
So the next,
So what happens if, or maybe, see, we don't have DOC in the room here for this. But if an inmate is discontinued on an opioid, on a MOUD. And doesn't notify the community prescriber. And then the person re-enters the community and goes back to their community prescriber. Can they get rehooked? Can they get hooked up again for the MOUD?
I'm assuming the community provider, if they hadn't seen the person for a while, would have to do an assessment and they wouldn't just rely on a previous prescription.
Would that community provider reach out to corrections at all, do you think?
I would
mean, that
guess it
would be a
depends
hard,
if
right?
they know the person has been at
If they know, yeah. Just thinking.
That's dangerous.
What did I think?
Yeah.
It's dangerous. It's more dangerous if I don't.
Yeah, that's true.
Okay. So subsection D is not eliminated, it's been moved.
Yep.
Okay. So subsection E. Counseling or behavioral therapies shall be offered in conjunction with the use of medication for opioid use disorder as provided for in the Department of Health's MAT for opioid dependence. Medication assisted therapy for opioid dependence for opioid-based treatment, OBOT providers, prescribing buprenorphine, or opioid treatment providers, OTPs. So when we last were here, or I guess last week, I said I would double check if the name of the rule had been updated since this was enacted, and it had been. So this reflects what is currently the title of the rule.
Actually, Katie, for the record,
Tony,
Tony,
welcome.
Department of Health, Division of Substance Use. I believe there's an emergency rule in place that actually has a different name change.
Okay.
That's what we
And it's-
need, right?
Yeah, and it's listed still as an emergency rule because we were waiting on the final federal guidance on whether or not a in-person medical visit was going to be required before commencing buprenorphine, and if so, at what interval that would be expected, so we could stay in alignment with the new to becoming federal rules.
Has a permanent rule been filed yet? Sounds like no.
I don't believe so, but I will send you the rule as it exists now that we have.
Has it been through Elcar? Or not yet?
Yes.
It is, so it's currently in effect.
And it's a different name or it's an emergency rule?
No, it was a change to the rule, and we had done it as an emergency change because we weren't sure what the long-term changes were going to be. We needed to remove like previous references to individuals having to receive an X waiver or the training that was required for any DEA licensed medical provider. That was removed. Some of the other caps were removed. So we had filed it as an emergency, knowing that we needed to get those things out so that we were not more restrictive because we didn't want to be than the federal government.
Was the name of the rule changed when you made
It
those
did.
other
We
changes?
changed it to medications for opioid use disorder. So
Okay.
I will
So-
send it
And
to
then-
you.
Send it to.
Need to cite and statute an emergency rule because it could change again. So my suggestion is maybe to refer to it generically as the Department of Health's rule on MOUD or something generic and not have a title.
That makes
And-
sense, because it will be readjusted now that the federal government has given us an indication at least of what their expectations will be post-COVID for how frequently somebody will need to be seen for an in-person examination after starting buprenorphine.
Thank you.
Kevin,
Can someone remind me who does the counseling or behavioral therapy?
it would be within DOC, would be within WellPath.
It would be WellPath.
And it's offered. It's not required,
Right.
even provided, it's still offered.
Mhm.
It's not a requirement, and that tracks what happens out in the community. Correct, Tony? Because that was very clear when we put this in place. We didn't want the MOUD program in corrections to be more than what's offered out in the community, and we didn't want it to be less. So
Yes,
it's.
that is correct.
So in the community, counseling and or behavioral therapies is offered to anyone who is involved in the MOUD program, but it's not being required. So we want that to be consistent. Anything else for folks? Okay,
Brings us to the top of page 10. Subsection F. This is the language that was struck through earlier and I said it moved. Here it is. Oh no, that's
oh, it's gonna.
not. Oh, it was G. I'm sorry. It's G. So I reserve that comment for when we get to the bottom of the page. As part of reentry planning, the department or its contractor shall provide information and offer care coordination to an offender to expedite access to counseling, behavioral therapies, and medications for opioid use disorder within the community. The department or its contractor may do the same for a detainee.
And that's what you moved into the earlier section as well.
That sentence, yeah, that sentence is going to appear a couple times now.
Sentence is that department or its contractor?
Line 4, and
oh, line
line 4 onto
four.
line 5, we
Okay.
moved that earlier into the statute as well. Or into the,
Mhm.
And then what this is showing is that right now, what I'm showing on the screen is sort of showing up as two separate paragraphs, but because we're striking out the subdivision, it's going to be compressed into one paragraph.
So the first part of that, I want people to understand what it's saying. So for the committee, what is the distinction between line 1 and lines 4? The first part of that paragraph is saying what, and what is that last sentence saying?
Here, I was gonna ask that question.
And keep quiet, Troy. I want people to look at the language. What does the language say on line 1 and line 2?
Notice that.
To an offender.
Mhm. And then what does it say on line 4?
And if we can,
So what's the difference?
Offender is detainee. The offender has been charged, the detainee may not have been.
They've both been charged.
Defendant's been adjudicated and convicted.
The offender is a sentenced person.
Oh, yeah, I'm sorry.
They've been sentenced.
Sentence, I'm sorry. Used the wrong-
And detainee, they've only been charged.
Right.
It's just, that's fundamental in understanding this. So there is a shall, so if a person is incarcerated with a sentence and they are reentering, the department or its contractor shall, they need to offer coordination. If it's a detainee, it is a may. They don't have to offer it to the
they can
detainee.
use their better judgment.
No, it's because of the flexibility with detainees. They may be leaving the court instead of corrections. Corrections doesn't have control of when a detainee leaves the facility. That's up to the court
and they may not want to provide reentry planning if the detainee's only been there overnight.
or a week or two, or they may bail. They could all of a sudden make bail after 2 weeks.
So they don't have jurisdiction over that person?
They have jurisdiction over the person when they are in their facilities, but the person has not been adjudicated. The person has been
Okay.
charged. The court has sent the person to corrections to be housed for a variety of reasons. It could be they put bail on the person didn't make bail. They're housed in it could be sent to a correctional facility held without bail. But usually if they're sent to a correctional facility, there could be a high risk of flight and bail isn't going to take care of that, or a risk to public safety. They want them in a confined area to make sure that they show up for court.
Mm-hmm. So that's a detainee.
I will point out too, that detainees may be with the Department of Corrections, detained by the Department of Corrections for sometimes years.
Wow.
3
And it is
years,
my
4
hope.
years, right?
It's my hope that those people will get reentry planning, because it's probably more likely than not that they will know when they're being released. And
They're
that's
more
one of the
likely than
reasons.
not to be sentenced too, if they're held.
Sure,
alone
or
for a period of
released
time.
after serving minimum.
Right,
right?
time served, yeah.
This is precisely why I asked if we want criterion for that May. Like, is there a set of parameters where we do want that reentry planning to happen and where we don't necessarily need it to happen? We heard from the Department of Corrections that they didn't necessarily need criterion. And I'm fine with that. I'm worried that creates a loophole for the Department of Corrections to say, we don't have to. I'm not worried about that with this Department of Corrections, but in a general sense, that's why I think we have an obligation, if somebody's been detained with us for a year or two, to help them re-enter, just like we do sentenced folks. But there's just not a way to really kind of carve that out in this language, I don't think so.
Well, this depends more on WellPath than on the DOC, does it not? So you're talking essentially about medical malpractice, which the inmates could grieve.
Well, this is counsel, this is like the whole kind of umbrella thing of reentry planning, getting them set up with somebody on the outside. Getting
If that's
them,
medical best practice, then
I agree.
yeah.
Yeah, it's ultimately the department's responsibility or its
Yeah.
contractor.
No, and yes.
Anyway,
Required to do
I'm
that.
fine with the language. I don't need to change the language, but that's been kind of at one of my kind of
Churning.
core concerns with
So
what we do.
required for care coordination for someone who's sentenced, because they're under the jurisdiction of DOC. A detainee could be there for 2 days, 4 days, a week. Could be there a month and they make bail. Okay? Or they could be there for 2 or 3, 4 years before they go to trial. And then they have their trial, or they make a plea agreement and say they've been there for 3 years as a detainee. And they're sentenced to 5-year minimum, 10-year maximum. But they get credit for time served. So they get credit for those 3 years they've been a detainee. So they'd have 2 more years for their min. Or maybe their min is equivalent to time served, and then they could be released. So Joe and then Char.
That's what I believe Isaac testified that the median detainee hold time is like 3 or 4 days.
Right, it's
The
very,
mean is much higher because you have select individuals that are held for, serious offenses for prolonged periods of time.
and most times if they're held for a long period of time, they are going to be sentenced. It's usually the case. Depends how much of credit for time served has played into it. Sean?
I don't know if this is something you can answer, Katie, or Tony has to answer it, but like how can someone be detained for 3 or 4 years? That's really mind-boggling. And how many people are we talking in our corrections that are detainees
500.
for into the, let's call it the
About 40%.
3-year mark?
500.
It's about 500.
There's 500, but there's a constant churn, and some of that's your federal. And in terms of how can they be there for 3 years, a variety of reasons. It's up to the courts when they come back. It's up to negotiating with your lawyer. It's up to the prosecution, it's up to the victims, and they may think the case is ready to go, and there could be new evidence that comes in. So then you gotta start over.
But what if,
Again.
what if he is innocent?
Well, you gotta prove that in court. That's the whole point of going to trial. You gotta prove your innocence.
But if
So
he
there could-
hasn't gone to court for 3 years,
But the prosecution is working on the case. The defense counsel is working on the case. There's work that has occurred through that whole time frame. And the more egregious the crime, the more time it's going to take
Gotcha,
to build
okay.
your case.
Right.
Because your state prosecutor is building the case. And then the defense is building their case and they're talking to witnesses, they're doing depositions. And they're building their case and all of a sudden they might get new evidence
Okay.
on either side.
So this is more serious
Or
stuff?
it's- Well, your longer term ones tend to be
Okay,
more serious, but still, each entity has to build their case. They could go into court for status reviews, and there could be a court date set, and then all of a sudden it's like, well, maybe I want to find a way so I don't have to go to a jury trial. And then you make a plea agreement. Most cases, 97, 98% of the cases are resolved in a plea deal.
Okay, gotcha.
who determines when it's time to go to court?
That's determined by the state prosecutor, by the defense counsel, and the schedule of the court.
Okay, so they gotta agree to that.
They gotta figure out a court date that's works for the court, so when the judge. And if your house in St. Albans, you may have to come down to Washington County. Or you may have to go down to Windsor County, depends where you're being housed, so you have, all of that has to come in.
Johnny testified.
Or you have to go through this of us learning what
It's complicated.
a offender and a detainee is. Thank you.
But I think Judge Zone said yesterday in different contexts, but for even run of the mill, criminal docket times, you're looking at 5 or 6 months right now.
At least. Because you gotta schedule that with the courts, because they're backlogged.
Okay.
So there's a lot of time you just wait.
Okay.
Because there isn't court time available, because it's such a backlog of cases they've got to work through. And it depends on what court you're going through. So it depends where you committed the crime, where the crime is being charged.
Always happens in time.
So if it's in Windsor County and they're being held in Newport, the person has to show up in court in Windsor County.
And this is trivial, and I'll stop after this, but if the prosecuting attorney says, I'm ready to go, I got all I need,
The defense may not be,
right, and the defense says, no.
or vice versa.
Well, I know vice versa, but if you can't come to an agreement, is that when,
Well, that's when the courts, they'll figure it out.
then the court says, you guys have had long enough?
I mean, I would assume.
And would that actually be the judge, or would that be,
I don't know.
okay,
I don't know.
enough,
You
that's,
wonder why there's, and you wonder why there's backlogs.
right.
So that's beyond Katie's jurisdiction. That's a question for Ben and Eric and Judiciary Committee.
I would love to talk about this with you.
And poor Katie is going, I don't want to hear this. You'll learn something about corrections though, right?
Absolutely.
Probably more than she wants.
Are we ready to
Yes.
get going on line 6? Okay. The department or its contractor shall identify a healthcare practitioner or an opioid treatment program or both, and schedule an intake appointment for the offender with the healthcare practitioner or opioid treatment program or both, to ensure that the offender can continue treatment in the community as part of the offender's reentry plan.
So that's for the offender. Okay,
And then the department or its contractor may do the same for a detainee. The department or its contractor may employ a caseworker or contract with the health navigator to assist with scheduling any healthcare appointments in the community.
so that's to continue their program. Not just the medication, but the program.
And then you have subsection G, this is what had moved. As part of reentry planning pursuant to this chapter, the department or its contractor shall commence medication for opioid use disorder prior to an offender's release and may commence medication for opioid use disorder prior to a detainee's release if the offender or detainee screens positive for an opioid use disorder, medication for opioid use disorder is medically necessary, and the offender or detainee elects to commence medication for opioid use disorder. If medication for opioid use disorder is indicated, and despite best efforts, induction is not possible prior to release, the department or its contractor shall ensure comprehensive care coordination with a community-based provider. If an offender or detainee takes a medication prescribed in the course of medication for opioid use disorder while incarcerated, and that prescription medication is both available at the facility and clinically appropriate for the offender or detainee at the time of discharge from the correctional facility, the department or its contractor shall provide the offender and may provide the detainee at the time of release with a legally permissible supply to ensure that the offender or detainee may continue taking the medication as prescribed prior to obtaining the medication in the community.
So that's different than if they're under the medical piece. The medical piece, they get 28 days in a prescription. This says what? On lines 13 and 14. This one's different,
Whatever the legally permissible supply is.
which could be a couple days.
It could be 3 months, who knows, right?
I don't think they're gonna,
Text.
Do that?
they're not gonna let somebody out with 3 months.
Okay,
What the key is, they'll give them enough to get them so they can have an appointment with a hub.
Okay. So-
They may not get into a hub for 3 days or 4 days. They want to make sure they have the medication at that point. So Tony, what would be legally permissible supply?
Don't know that there's any real definition of legally permissible supply at this point. Most of it is dictated by what insurers would cover at any given time, and that tends to be 30 days maximum. The point, as you made it, was we're really trying to make sure that we write bridge prescriptions from when somebody leaves to when they get to their next appointment, so that folks don't have extra medications that would be difficult to reconcile, and they're left with extra medications that may be tempting to do things with that aren't helpful to their recovery.
You want a short period of time. And that's why you want to make sure, if you go up to number 2, department or its contractor shall ensure comprehensive care coordination with a community-based provider. It's to get all of that in place before a person's actually released. That's what is important for G, that's starting on page 10. As part of reentry, the department or contractor would commence MOUD prior to release. And then if it's indicated, the department and contractor shall ensure comprehensive care coordination with a community-based provider. That's to ensure that when the person is released, that there is a connection for that person with a hub or a spoke, so that they can continue an MOUD with the hub or the spoke. That's what this language is all about. Is that fair to say, Katie?
This language is about what somebody takes with them out of the facility to sort of get them by until they can use their prescription.
So unless they actually have an appointment set up, it's a best guess as to how much prescription they should be receiving.
You mean the number of days?
Unless they've got a doctor's appointment 7 days from now. How do
So
they determine it?
if you look on lines 5 and 6,
Okay,
shall ensure comprehensive care, it's the department of contractor.
Not may.
and that implies we're able to do that. I mean, there's plenty of times that people call and they can't get an appointment with a doctor for months and months and months.
I can't.
I can't,
I know.
and I'm not asking for
I know none of us can.
controlled substances, so
So if you go to page 10, and lines 6 through 14. Read that.
They're supposed to hook them up with it.
Says it's a reasonable lift, not a heavy lift.
But it's up to the department or the contractor to make sure that there is continuity in the community. Because they can help to, and this is testimony we received last year from WellPath, that this is what they do now. We wanted to make sure it continues regardless of who the contractor is. And that it's the department or contractor would schedule an intake appointment for the offender with a healthcare practitioner or opioid treatment program, or both, to ensure the offender can continue treatment in the community. So they know the person's being released. Let's get this all set up in the community before they're released, and not leave it up to the person to do it. That's what this says. And that's an intent to get in quicker.
Okay.
That's
I'm still in the maze that they are finding to get them into these different programs, because I know in our community, a lot of them are very hard to get into. Now, I wanted to be there for folks, but
Can I ask Tony?
Mhm.
Hey, Tony,
Yes.
just because, you're the, expert here. Do people like that come out? Does it work pretty well when they get out of correctional facility? They get hooked up with someone is that a problem or not?
I think going back to what Dr. Lord said to all of you the other day, I think when we know the release date, it actually works quite well. Many of these individuals were already being seen in the community. That is a very easy lift. They go back to the medical provider with whom they were receiving treatment before. For new individuals, for folks who were initiated in the Department of Corrections, in each location, we've really identified addiction medicine specialists, just saying that we don't know how you react in the community. We only know how you reacted in a contained environment. So we want to make sure we give you a specialist who can manage things in case things are a difficult transition. And they do an amazing job of getting folks in. And then if all else fails, particularly for the detainees who become released unexpectedly, the hubs will admit 6 days a week, sight unseen, as part of the Department of Corrections. So if somebody leaves the Department of Corrections unexpectedly and they walk into one of the hubs, and all of them are supposed to be informed of the locations of the hubs closest to their location in case they leave unexpectedly, they walk in the door. We will get them medicated that day, and we will verify that they have been with the Department of Corrections. We will ensure their care Monday through Saturday.
Great, thank
We
you,
did that
sir.
because we didn't know what else to do for fail safes for folks that would be released, or for those individuals who may be released who were in only a short time, but they didn't go in with Medicaid, so they don't come out with the health insurance. We are able to offer that as kind of subsidized care or largely free care to those individuals to make sure that they are also seen by going through the hubs, because we provide grants to the hubs to treat the uninsured and underinsured.
Okay, great.
Questions and answers.
Okay, let's go to line 16. So you got to figure this one out.
So, we have had a discussion a couple times about whether DOC staff shall receive training on MOUD, not to be providers of MOUD, but to understand why it's given. And there hasn't been a decision.
I tried to get DOC in to talk about this, and just the schedule has been full.
I think it would be a very good idea. Can we craft a paragraph there that is loosely encouraging and permissive of the department to do that kind of training?
Sure.
And that will be done at their academy, and we've wanted to get folks in to talk to us about the general training that occurs at the academy.
Right, this just doesn't.
Can we at least add to that what the purpose of the training is?
I think kind of what you just stated, Katie,
Mhm.
understanding the general
The
sort
why,
of
the why and the how?
best practices.
Yeah.
Yeah, yeah.
Because there is a lot of resentment sometimes from the staff, thinking you're keeping them addicted. And and part of this is the way it was rolled out initially, MAT. There was, I mean, all of a sudden it just got rolled out in all facilities, and the staff was like, what's going on here? And there wasn't the knowledge or the understanding of why. So,
Tony, what's your thought on being able to provide that sort of training at the academy level?
Oh, I am off mute. My apologies. Historically, I've done some trainings at the academies. I know when this was first rolled out, Annie Remniciano on behalf of corrections went out and did introductory trainings at all of the facilities. But we also know that turnover exists.
Yeah.
So I think if history is an indicator, and I don't want to speak for the Department of Corrections, but if his history is an indicator, they have been both receptive and willing partners to put this together as part of the orientations.
And it's not an unexpected it's not an unreasonable expectation of your office?
No, whether we did it or whether somebody else they wanted to do it, no, that's not unreasonable. In fact, as we've rolled this out in all the emergency rooms around the state, we've done the same series of trainings as well to make sure that healthcare providers were also recognizing the fact that they needed to understand the purpose, the medication, and the biases that are potentially exist there.
Great, thank you.
And then Tony, is there ongoing professional development, or is it like a one-off when you start, or how does it work usually?
So there doesn't tend to be, for the non-medical staff, for non-healthcare providers, there doesn't tend to be a lot of ongoing. For the healthcare providers, we do a learning collaborative series with Dartmouth that we offer both virtual trainings and then an annual in-person training. We do 10, 11 trainings a year on various topics related to medications for opioid use disorder and all of the potential other substances of misuse that occur with it, or other addictive behaviors, how to manage behaviors, how to do practice profile, like how to work together as teams. But it doesn't tend to be for the non-healthcare provider.
Gotcha.
Katie, you can work up some broad language in terms of what our intent is, maybe. Yeah. It's legislative intent or something.
And then,
I know it's section 3.
at one point, there had been a conversation about requesting information. So this is
This is a Kevin thing, where you want to track.
I'm wondering why, I have this.
It's green.
Well, this amends the same section twice. It took me a minute to remember what we had done, because this section 3 takes effect in 2027, so a year after the rest of the language takes effect. And I remember now that there was a conversation about the 1115 waiver
That's right.
needing to be in place. So this is an annual report from DIVA in consultation with DOC, is to submit to the policy committees. Let's see. Shall submit a report to the policy committees containing the aggregated number of previously incarcerated individuals re-entering the community in the past year who are receiving medication for opioid use disorder at the time of release. And of those individuals, the aggregated number of individuals who continue to refill a prescription for MOUD disorder 6 months after re-entering the community.
So we heard testimony from DIVA on this. I'm trying to recall, they wouldn't have access. They're there only for Medicaid. They wouldn't have access into the number of individuals would continue to refill a prescription. They would have access to whether person is on Medicaid or not.
Diva?
Diva,
Diva would have that, but they wouldn't have if somebody has private insurance.
right? But if they were on Medicaid, would Diva have access in terms of if they've continued, they would know if the person continued to refill their prescription?
That's a better question if they would have that specific detail. What I don't know is if they would know if the person had been in corrections.
Right. Right, there were some issues with this, with getting this data, from what I remember. There was issues with this. So we had Diva here talking about this. Do people remember?
Yes.
Oh, yeah.
I remember the conversation and
Yeah.
trying to remember if we talked about the two departments collaborating on their data to see if there was a way to
It was
split
problematic. It
overlap.
was problematic, from what I remember with Diva. That's what I remember.
You would be, DOC, I would think, would be able to track who has been released with a continuity of care sort of plan and of those who recidivates, but that's not quite what we're looking for.
I think, Kevin, this is trying to address what you were concerned about. They're on MOUD while they're incarcerated. Are they continuing being on there when they enter into the community? That was your concern,
My,
right?
my hope was to get an idea whether in fact this is helpful or not. And if this is incorporated and 90% of the people come back incarcerated, then I'm not sure it is helpful. That's what, and we should know that because if they was back, then we got that record. So if nobody shows up, if nobody comes back, then
But they may be coming back, but it may not be driven by their addiction.
true.
They may be maintaining on MOUD, but they've committed a new crime for a variety of reasons. So how do you delineate that?
But wouldn't we know if the offense wasn't for addiction, but for something else, but we'd know if they were opioids when they come back?
They could do a burglary, but it may not be connected to their addiction,
Right, but
or it may be.
But when they're being assessed on the way back in, if we see that if the opioids is a problem for them, then we'd have that record.
I'm having a trouble picturing who's the control population. Like folks who come out and were addicted and aren't staying on the medication, like who are we comparing those who recidivate
Well, at
to?
a minimum, if anyone who goes through and receives this benefit,
Yeah,
if they show back up and they're still they still require the medication, that statistic alone would help us know whether medically speaking, we're helping.
I'm going back to what Tony Fallon is saying. If they're continuing on an MOUD program and they're continuing it, it's very similar if you're diabetic and you're taking insulin and you're being successful. So a person could be on MOUD and they're very successful
Right.
on the program. They're maintaining their addiction, but they may have some other criminal activity because they're more wired for criminality than they are for behavioral issues.
Right.
So they could be maintaining their sobriety or whatever you want to say on the MOUD, but if they reoffend and come back, it may not be because of their opioid use disorder.
Right, but if they're coming back and they're still on Suboxone, for example, that's one thing, but if they're coming back and they're on oxycodone or some other illegal drug, that's what I'm saying. Yeah,
Okay.
yeah, if they're coping and they
Yeah.
are still on the medication, that's one indication. If nobody comes back with the need, then that'd be great. I mean, that'd be the minimum kind of accounting.
I'm still having trouble though. So do we then compare that to folks who never had the addiction to begin with and what their frequency of recidivism is?
So only the ones that leave requiring this service.
All right, so we're only looking at the population that comes out using that.
Right. Which
And
is
we're
about
comparing-
70%, isn't that the statistic we heard? 70% of the incarcerated
Something like, yeah.
need MOUD. So of those 70% are those people going out, if they never come back, we can say, wow, this made.
Well, or if they come back at the same rate as the other population.
Yeah,
But what you're really concerned about is if they come back, it's whether or not they're not abiding by their MOUD program.
Right.
They could be abiding by their MOUD program. That's not the issue you're looking
right.
at. You're looking to make sure that they are continuing with their program and they're not getting hooked on other drugs.
Correct.
Tony, is there anything you want to weigh in on this to see if that's possible or not?
Yeah, that's his opinion.
Yeah, I'm trying to think back. I pulled up the information that I can remember from the 2022 study that was done through UVM that took the DIVA data and the corrections data. And I was just looking at what they used for their metrics. And those were really about continuity of care, the number of folks released on medications for opioid use disorder who followed through on their first community appointments, or how many followed through in general. And so it was in 22, they said 70% of those folks who received medications and corrections followed up and received their next prescription within 45 days in the community. And I think that was the metric they were looking at. And then they looked at how many of those folks also had utilization of the emergency room within 30 days. So those folks that came out and immediately needed to access an expensive emergency room visit, whether that was appropriate or inappropriate, it doesn't say. I mean, there's certainly room for folks to go to the emergency room. They were just trying to look at, did it decrease utilization of potentially inappropriate utilization of the emergency departments. But it doesn't really give anything around kind of the question that you're asking about. How do we know that folks are staying, and how do we compare the folks coming out of corrections staying involved in care to affect recidivism versus those folks who potentially are staying in care but don't have criminal risk factors, and does it make a difference in some ways?
I just think it's going to be really hard to get this information.
It is.
Well,
I think it's
I don't
going
want
to
to
be
sound
really
cold.
hard.
If someone is released and they don't return, that's good enough for me, because we've done all we can. We can't babysit 100% of the population, but we have an obligation for those who we've incarcerated to give them the best chance of success. So if 100 people leave in the next two years and we see them back again and they still have an opioid issue, then maybe something needs to be adjusted with our plan to help them cope.
I feel like we'd almost have to compare the Vermont population to a different state's population, right? To have some group that's coming out without this sort of support.
That would be another way to look at it. There's
lots of variables there too,
Control
but
group.
right, exactly, yeah.
Have a control group. I just don't know how to approach this.
Well, because this is gonna be an expensive program. To do all this is gonna be significant money. So are we spending money? The only way you can know that is if you measure something.
Well, and I think that's what they're trying to get at, or at least one measure is emergency room visits, which are not cheap either, you know?
That's another key. Yeah,
Right.
if they're
Maybe it's just as simple to what Tony was saying. There was something that was looked at before to see how many emergency room visits occurred. And maybe it'd be easy enough to find out a number of individuals who continue to refill their prescription.
Yeah.
Yeah, for the Medicaid population, it's certainly, I think, probably easier than trying to get into what's called VCures or the all payer database. And Medicaid at least is the majority payer. So you wouldn't get exact numbers, but you would get the majority numbers.
So when someone goes into the emergency room, they would be identified, as a person who is on this program? I mean, how do you define?
It's identified via claims data. So my assumption, and again, I was not part of UVM helped DEVA do this, so they would speak better to it. My assumption is what they did was just looked at the lists of names of all the folks that came out of corrections within a year who had Medicaid, and then did I don't know what timeline they picked for parameters, 30 days, 60 days, 90 days, and said, here's what their expenses were. Here were their medical expenses in that period coming out the first 90 days after incarceration. They had 1 emergency visit, 2 prescriptions for buprenorphine, and whatever else. And I think that is my assumption on what they did, and then just picked the emergency departments are expensive utilization, and was it, they may not be able to drill down to was this an appropriate, quote unquote appropriate or inappropriate use of an emergency department, but did it, does it look like it's something that's within reasonable standard? And then how many people got to the first prescription of buprenorphine from the community, or first dispensing of methadone from the community who had previously coming out of incarceration. And so those numbers within the first 45 days was 70% had follow through.
And we can get that information notwithstanding HIPAA because they're still on parole or furlough or that's a question. I'm not making a statement.
They just do it as aggregate data. So it would be aggregate data. The health insurance could look at it, and then they just report out on aggregate data.
It's not individualized.
So we give them the names, but then they give us just the numbers? Is that what you mean by aggregate data?
Yeah. If it were 250 people, they would have the names. They would check out how many people that, they would follow the names and then just report back to us. 27 did this, 150 did this, and
That's all we care about.
Yeah.
So the way it's written.
I thought we could get.
The way it's written is there'll be previously incarcerated individuals in the past year who have been receiving MOUD at the time of release, that we would get information on how many of those individuals continue to refill a prescription up to 6 months after reentry. That's what this language is saying.
It's not what I was.
Have you worked up any other language, Katie?
No, I'm still trying to capture what you want. So it
Yeah,
seems
we're
like,
trying to capture what we want to.
yeah.
We're not having good luck.
So it seems like there's this interest in replicating what happened in the study in 2022. Is that?
Well, that was emergency room visits, right?
Yes. So, but you want to
emergency
capture
room
that.
visits and follow through to first
Follow.
appointment.
Was it emergency room visits for anything or for opioid use disorder related?
No, they just went with any rationale.
Okay.
I don't know if emergency room visits would necessarily give us anything that we wouldn't have a gazillion more things to sort out, but I do like first refill.
Mhm.
I think that gives us some good information about the efficacy of the reentry planning.
Right. Because
But I don't know. I don't know. I'm still thinking.
see, that's the problem for me. I'm not trying to dig into the weeds to make it more difficult. I just want to see that hopefully folks are being able to get the treatment and the meds that they need.
Yeah.
But we have kind of like kind of nothing, and And Tony, and I'm not saying this in a negative way, you're assuming they're getting it a certain way. You said my assumption is. And I'm like, I sometimes need to have some kind of, I don't want to say hard figures, but at least in the beginning to see that we are following through for these folks.
I think these were hard numbers. My assumption was that the method that they used. What they're showing here, that I just sent Katie the infographic that was developed out of it, that just kind of does the very quick visual. Those were hard numbers.
Well, and again, the devil's always in the details, you know.
Sure, of course.
With what you're looking at. I just, as I said, I'm not questioning you or
Yeah.
just want to make sure that whatever we're doing going forward is a real good, positive reentry plan for that for folks to succeed.
Right.
Absolutely.
To me,
Absolutely.
refilling the next prescription, maybe the next 3 to 5, I think would provide data that would indicate whether or not what we're trying to have them do is happening. I want to see those refills, right?
We got two things going here. So we got one part of the discussion is the refills. Are they successful? Are they getting their prescription refilled? That's one piece. Another goal, or a goal that's separate from that, is how effective is the MOUD program out there that we've set up in corrections that continue it out there, but they end up reoffending?
Right.
Are we being successful because they've reoffended? It's two separate things.
Yes.
And that's what we have to figure out. Which of those two do we want to do? To try to find the reoffense and try to figure out if it's MOUD related is going to be a difficult process, I believe. Because there's so many different factors that go into criminal behavior.
My recollection was that Alex McCracken and Isaac agreed to collaborate and provide some.
Language.
There was
Thank you.
Something came out of it.
Thank you. Yeah, I was trying to remember what was going on with
You
that.
want me to email
I'm
it?
sure you're right, but if they reoffend, they enter our facility and we assess them and they are still needing MOUD,
Yeah.
doesn't
No.
that's,
No,
If you go back to what Tony said, MOUD is a continuity of keeping you
oh, yeah, no,
stabilized.
yeah,
You're saying if they're on different,
something else.
on
If-
something else.
Yes, that's what I'm
That's
saying.
right.
If they present with something other than,
and they're not on MOUD.
right, so they come in heroin or whatever,
Fentanyl.
that's information we should
Crack.
readily have when they are re-evaluated coming in.
My guess is
They may have
that
been
already
stealing, but
exists.
they did it when they were on speed. I don't know.
My guess is that the data probably already exists, and
Right.
Isaac would know this about the intersection between recidivism and showing up needing assistance with.
well, can they
withdrawal.
actually show us something?
Right.
Because we've asked for simple reports
I know.
that they can't even provide.
Mhm.
So I'd like to know that at least it's being done. Again, I'm not trying to give them another report of that, but would like to at least see something that really constitutes that we're doing something positive.
So could, I hate to ask you this, Katie, but could you reach out to what it was?
Alex McCracken at DIVA and Isaac
Isaac.
Nano at DOC.
Okay,
And just see if
I'll do that
they
right now.
worked up some language.
Okay.
That's so we can move on here.
I may be missing the boat, but I'm still thinking if they come back, say they do recidivate and they're in withdrawal, then in a way this transition has failed. If they go out and successfully stay on their medication and recidivate, then we failed in a different way. And
No, if they don't show back up again, we've done all we can.
but I'm saying they do show up. In one case, they're
Back up.
withdrawal, in one case, they're still on the dupe or whatever.
Yeah.
There's just different failures,
I mostly want, I mean, this is a continuity of care bill, right? And I want to know if it's helping the continuity of
Right,
care.
right.
For me, the measure there would be this person left our facility on a treatment plan, and they've successfully refilled the next X number times would indicate to me that continuity of care is present.
They're staying on their maintenance drug,
Yeah,
and their maintenance program,
regardless of whether or
whatever
not,
it is.
yeah,
Because it's MOUD, they're staying on their maintenance
yeah,
program.
Well, that seems like capturable.
I agree.
That's what,
That seems quite easily capturable. That one.
so if we could, see if the two entities work up any language, would be great. So Katie, I'm just looking at timing and your schedule, when we can get a new draft.
Yep. Sorry, I'm writing this email to Alex and Isaac.
No longer.
Yeah, I did find my notes on this, and Diva's testimony was that they don't have the data on if they were incarcerated.
Really?
A significant administrative lift.
We have,
That's
that's what I think DOC needs to figure out.
You said that, I remember, but I couldn't.
Anybody right now, if they've served their time and they're fully released, why would we?
And then she said it, I was like, I remember her saying it was gonna be too much for them to do.
If they're on parole.
Yeah, but then we'll
Do Friday at 11.
I'm sorry,
Friday at 11.
Often people are.
Friday at 11, is that what you said? Do we have time? Friday? We're free on Friday, right? And we're free tomorrow, totally. We don't have anything tomorrow
We have state's attorney on 379
at 9.
at 9,
At
and then
9.
at 10, we have BGS.
Yeah, on
and
Windsor.
Fish and Wildlife on Windsor.
Can we try to do a trip to the Dome tomorrow afternoon?
Yeah, I can,
Check with Joe,
yeah.
because I don't think we'll be on the floor too long.
Anybody remember Joe's last name?
No, it's the police officer, Capitol Police.
I'll figure it out.
Yeah,
Tremblay, or
just ask,
I think it's Tremblay.
ask Agatha. So 11 o'clock Friday,
Yeah, that works. We can.
and we gotta have DOC in the room. I really want DOC in the room. Tony, can you make 11 o'clock on Friday?
Give me 1 second.
I mean, we need
Madam Chair.
DOC in the room. Or just on Zoom or somebody, because there'll be questions coming up with DOC. I would think they could provide somebody.
Yes, ma'am. I should be able to make 11 o'clock on Friday.
Okay, well, let's do that. We'll just have to say, we need somebody from DOC on Zoom or in the room. They got people they can pull. I would think. Thank you, Katie.
Yeah, no
Thank
problem.
you so much.
I'll see you Friday.
You don't have too many changes to make, right?
No, but I have my to-do list is very long right now. So
On this,
I'll take the 2 days. No,
no, it's your to elsewhere.
I do. Keeps me out of trouble.
It's that time of year. Thank you, Katie.
Yeah, no problem.
Thank you.
Thank
Okay.
you, everyone. Have a
Thank
lovely
you,
night.
Tony. We're done for the day. For the
Have a
day.
great
Thank
evening,
you.
everyone.
Yes, we'll see you on
You too.
Friday.